So we'll check out the drugs in psychiatry. So psychiatric illness can be divided into psychosis and neurosis according to the insight present or absent. Neurosis, you have generalized anxiety disorder, phobias, OCD, bulimia, PTSD. Schizophrenia and mood disorders come in psychosis in which there's no insight. Mood disorders may you will have mania, depression, manic depressive psychosis, termed as bipolar. So drugs in psychosis, you have antipsychotics. In schizophrenia, you use antipsychotic D2 blockers, which are termed as typical, and any other mechanism से अगर कुछ हो रहा है तो typical, especially 5-HT2 blocker. Now there is no distinct blocking in these two. Both of them can block D2 as well as 5-HT2, but the ratio, if it is more than 1, then it is termed as typical. If it is less than 1, then it is termed as atypical. Now there are three types. There are strong D2 blockers, there are weak, and there are intermediate. तो स्ट्रॉन्ग में आपके हेलोपेराडोल आते हैं सबसे ज़्यादा, तो इस पर ही क्वेश्चन आएंगे. ड्रोपेरिडोल, फ्लूफेनाजीन. द एडवर्स इफेक्ट ऑफ दीज विल बी एक्स्ट्रा पिरामिडल सिंड्रोम्स. क्लोरप्रोमाजीन, थायरोडाजीन, दीज आर वीक D2 blockers. So adverse effect इसके अल्फा ब्लॉकिंग, acetylcholine blocking, antihistaminic. Thiothexine and chlorpromazine are intermediate blockers. ठीक है. Then so antipsychotics जो हैं they will be used for schizophrenia, psychosis, mania, Tourette syndrome, agitation, OCD, Huntington's. It can be typical or atypical. Typical, you have D2 blockers in which you block dopaminergic transmission in the mesolimbic pathways, and this will treat positive symptoms of schizophrenia. What are positive symptoms? Something which are added to a normal being. These are positive symptoms. So adverse effect may extrapyramidal syndrome. This increases the prolactinoma due to D2 inhibition, which is gone. Increased risk of stroke. VTE will be there. There will be alpha blocking activity. So anti-alpha 1 orthostatic hypertension will be there. Acetylcholine blocking will be there. Antimuscarinic activity like dry mouth, blurred vision, urinary retention, and constipation will be there. Then antihistaminic, sedation, weight gain, hyperlipidemia, all these will be there. Increase in the prolactin, galactorrhea will be there. Oligomenorrhea, gynecomastia, impaired glucose tolerance, neuromuscular NMS will be there. Then increase QT interval, decrease in the seizure threshold. Chlorpromazine, corneal deposits will be there. Thyroidazone, retinal deposits will be there. So extrapyramidal syndrome, you will have Parkinsonism, acute dystonia, which is the earliest to occur, akathisia, and tardive dyskinesia. Parkinson's syndrome, you will treat with benzexol. Drug of choice are anticholinergic agents. Now the management of psychosis in Parkinson's is Q-tipine. ठीक है, but Parkinson's due to atypical or antipsychotics will be treated with benzexol. Acute dystonia, this takes hours to days and it is the earliest to present. There is sustained muscular contraction and torticollis, oculogyric crisis will be there. You will again treat this with benzexol, benztropine or diphenhydramine. Akathisia, this is severe restlessness. First, you have to reduce the dose. This is the most common one to occur. And treatment will be propranolol. Tardive dyskinesia, this is last to occur and usually take years to occur. There is chorioathetoid movement, involuntary, it occurs in 40%, it's irreversible. And there will be chewing and jaw pointing, excessive blinking. So Everywhere else you use benzexol to treat the extrapyramidal syndrome due to antipsychotics, but in this case, the mechanism of action is different, so you benzoxazole is actually contraindicated. The treatment is valbenazine in this case. So what is the pathogenesis for tardive dyskinesia? Usually it occurs after withdrawing antipsychotic drugs. So basically dopamine will act on the D2 receptor, and D2 receptors are blocked, and it is so there are the other receptors are super sensitive, and they will increase the opposite action of dopamine. All other extrapyramidal syndrome symptoms actually have D2 blocking excessively. Here there is super sensitivity. So anticholinergic drugs can be used in all other extrapyramidal syndrome except in EPS. So when you block D2, there is increase in the prolactin. There is blockage of acetylcholine, alpha blocking, H1 blocking, and seizures. There will be violent behavior, well controlled by typical. Okay. Now we'll come to other side effect, which is malignant neuroleptic syndrome, and in this case you will treated with dantrolene. So okay, so this is all extrapyramidal syndromes. Now typical will block D2, D3, D4, 5-HT, and this will treat both the positive as well as negative symptoms of schizophrenia. So typical में you have haloperidol, pymoside, trifluoperazine, flufenazine, thiaridazole, chlorpromazine, and atypical में you have pines and dones. So you have aripiprazole, which is partial D2 agonist, acinapine, clozapine. Clozapine can cause a granulocytosis. It can cause seizure, myocarditis, sedation, which is most common, and as well as cialorrhea. Olanzapine can cause metabolic syndrome, which is very famous. Quetiapine will cause cataract. Iloperidone, paliperidone, risperidone, lurasidone, and ziprasidone is there. Ziprasidone will increase the QT interval. Now there is pimavanserin, which is atypical, and it is used for psychosis as well as Parkinsonism. Now cialorrhea will be alpha 2 blocker, M4 present will be there activity. So cialorrhea, alpha 2 blocker, and M4 activity because of this. SSRI inhibit 5-HT reuptake, and it is used for depression, generalized anxiety disorder, panic disorders, OCD, bulimia, binge eating disorder, social anxiety, PTSD, etc. Fluoxamine, paroxetine, escitalopram, and citalopram, fluoxetine, sertraline. So these are the ones which will definitely come in the exam. So citalopram and fluoxetine are the first line drugs in children, and sertraline is especially used post MI. What are the adverse effects? There will be JIT inhibition, most common side effect. There will be increased risk of GI bleeding, so you have to give PPI along with this. There will be anxiety and agitation. Citalopram dose dependent QT increase, maximum 40 milligram per day. It takes 4 to 8 weeks to show effect. Interactions: NSAIDs with PPI, warfarin with heparin, or heparin with mirtazapine. Aspirin, triptans, and myoinhibitor. Triptans and myoinhibitor will increase the risk of serotonin syndrome. Now discontinuation over 4 weeks. Paroxetine has got the highest symptoms discontinuation के लिए. So clinical feature first increases the mood changes, restlessness, difficulty in sleeping, and GI symptoms will be there on discontinuation. Paresthesia and unsteadiness will be also be there. Now, SSRI first trimester में increases the risk of congenital and heart defects. Third trimester में it causes persistent pulmonary hypertension. So they are contraindicated. SNRI inhibits 5-HT plus norepinephrine uptake. It is a drug of choice for severe depression. Venlafaxine, panic disorders, PTSD, OCD. Now these are also used for SSRI. Depression, GAD, diabetic nephropathy. Then deslafaxine, duloxetine, levomilnacipran, and milnacipran. So duloxetine and milnacipran, both of them are used for fibromyalgia. Adverse effect increases blood pressure, stimulant effects, sedation, nausea will be there. Tricyclic antidepressant, 5-HT inhibitor and norepinephrine inhibitors. So these are like similar to SNRI. They are amitriptyline, nortriptyline, imipramine, dispyramide, clomipramine, doxepin, amoxicillin. Then you have, where will they be used? Mood disorders, peripheral neuropathy, chronic neuropathic pain, migraine prophylaxis, OCD, clomipramine is used, obsessive compulsive disorder mein. Nocturnal enuresis, imipramine is used. What are the adverse effects? Again, they will block acetylcholine alpha blocker, H1 blocker, and seizure. So similar adverse effect. You have to strictly avoid in cardiac patients in arrhythmias. Overdose will cause